think we have 8 people on. We can wait.
Sure, we can wait a little, but
Yeah.
Yeah, I just went ahead and started recording.
That's fine. All right. Well, welcome. We are excited to join, to start our meeting. And we're going to wait just a little bit to allow more people to join. We are 1 after 6, and I want to be mindful of everybody's time, but I want to make sure that we give everyone a chance to log in, set their volumes and things like that. So we'll start just in a little bit. Well, okay, I'm going to go ahead and start. Welcome to our Southeast SCCM chapter meeting for June. We are excited to have a very engaging topic, a very relevant permanent topic. We will start all of our chapter meetings with a reading of our mission and vision. So our mission is to secure the highest quality care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. The vision of the Southeast SCCM chapter is to provide all critically ill and injured patients in the Southeast region will receive care from a present integrated team of dedicated trained intensivists and critical care specialists, as well as inspire new leaders and providers of critical care in the region. And just as a reminder, our Southeast chapter of SCCM represents the Southeast region of Alabama, Arkansas, Georgia, Kentucky, Louisiana, Mississippi, and Tennessee. We are a multi-professional organization that is composed of physicians, nurses, pharmacists, respiratory therapists, physician assistants, and other healthcare professionals. And our goal is to encourage SCCM membership at the national level and also to build the Southeast chapter while providing education and network opportunity to its members. And you can go ahead and like us on the Facebook link, and we will have links later on the slide. And just a few announcements before we start hear from our speakers today. We want to thank everyone who participated in the National Critical Care Awareness and Recognition Month in 2025, and these are the different hospitals that participated. And on the next slide, you'll see pictures of those who submitted and celebrated to recognize providers for all the hard work that they've done in the ICU. So again, this is just a celebration. It happens every year, and this is a national movement, but these are some of the ways that members of the institutions in our region celebrated this in May. So it's Turner ICU Blue Day, and these are the different ways. So thank you so much for participating, and we do this every year. If your institution is interested in joining us, please look out for information coming up next year. All right, and again, we'd like to highlight some of our upcoming events. Our next event coming up in July, which is right around the corner, is a bite-sized lecture on, the topic is entitled From Collapse to Recovery, Management of Cardiogenic Shock. And you can go ahead and scan the QR code that's on the slide right there if you want to register. And all of our bite-sized lectures happen at 12:30, and our next one is July 16th. And you see speakers, our speakers are listed on the slide, and we have a representative sample of speakers from the University of Kentucky Healthcare. Also here in Atlanta at Piedmont Atlanta Hospital, we also have 2 speakers, and this represents a multi-professional group. So stay tuned. We also have our upcoming August meeting, and we are so thrilled to be able to have the current president, the national president of SCCM for 2025, Dr. Jose Pascual, is coming to give a webinar. And so he will be presenting on contemporary care of traumatic brain injury in the ICU. And this will be August 21st. 2025 at 1 p.m. Eastern Time or 12 p.m. Central Time. And again, the QR code is there for you to register, but we're really excited to be able to have him come and speak to our chapter on this very important topic. As always, if you have a topic that you'd like to hear more about, please let us know. You can contact us with our at our email address there, communications@sccmsc.org, for any future topics or speaker suggestions. We are open, and as we continue to plan our year. And in addition to Facebook that I've mentioned, we are also very active on various social media platforms, including X, which our handle is @SCCMSE. We're also on Instagram, and all of our past meetings are posted on YouTube, so you can follow us there. And of course, we love to hear from you, so please definitely tweet or post during our meetings, and that way we know that you're out there. Thank you. For this current meeting that we are about to have, it is approved for CE. And so after this meeting, you have 2 weeks to complete the CE survey after the talk. So the link for the evaluation is right there. So again, scan the QR code. You must complete your evaluation by Tuesday, July 8th, which is 2 weeks from today, in order to have CE for this talk. So again, this is a member benefit that we have for you for participating. And again, we'll also send out the link to meeting participants based on your request if you don't get the QR code here. So always email us at communications@sccmse.org. All right, I think we're ready for our speaker. So today we are going to be having Dr. Philip Yang. The title of his talk is Corticosteroids and Sepsis, ARDS, and CAP 2024 SCCM Guideline Updates. And he is an assistant professor of medicine in the Division of Pulmonary, Allergy, Critical Care, and Sleep Medicine at Emory University. His clinical and research interests are in the application of bioinformatics and machine learning techniques to better understand phenotypes of sepsis, acute respiratory failure, and acute respiratory distress syndrome, and to investigate how the phenotypes respond differently to tailored interventions. So thank you so much, Dr. Yang, for joining us, even though you're in a different time zone. So thank you for having us, and we look forward to your talk.
All right, thank you so much for the introduction, and thank you for having me. Can everyone hear me okay and see the presentation?
Yes.
Okay, great. All right, so let's get started. Hi, everyone. My name is Phil Yang. I'm one of the faculty members in the Pulmonary and Critical Care Division at Emory University. And I'm really excited to talk to you today about the updated SCCM guidelines for using corticosteroids in critical illness syndromes such as sepsis, ARDS, and community-acquired pneumonia, or CAP. I don't have any disclosures relevant to this talk. So before we start, I'll just start off by saying that obviously corticosteroids in critical illness syndromes, the pathophysiology and like the pharmacology can be very complex. And it's in some ways it's impossible to go over everything in detail within an hour time frame, but I will try my best to highlight the most relevant literature and kind of put everything in the context of all the historical clinical trials and what's been done in the past and what the new evidence shows. So hopefully that'll be helpful to everyone. The learning objectives for today are going to be to review the physiology of critical illness-related corticosteroid insufficiency, or SCCM, and then we'll review the updated guidelines for the corticosteroid therapy in sepsis, ARDS, and CAP. These are the 2024 guideline updates published by SCCM last year. And I'll try to highlight the main differences coming from the most recent guidelines from 2017 and how the updated guidelines differ from the previous recommendations. There aren't any major changes per se, but there might be some changes and updates regarding some of the nuances of some of the treatment considerations. So I'll highlight those as we go along. And then we'll also discuss some areas for future research for corticosteroid therapy in critical illnesses. So the outline for today's talk, first we'll review the background information and physiologic rationale for steroids in critical illnesses and SCCM. And then we'll highlight the recommendations from the updated SCCM corticosteroid guidelines for sepsis, ARDS, and CAP. And then we'll leave some time for summary and questions at the end. So some background information about corticosteroid physiology. So this figure shows is like a summary of the corticosteroid physiology, both in normal healthy state as well as during stress or in critical illnesses. In normal healthy state, I will just start off by reviewing normal physiology. The corticosteroid physiology is regulated strictly by the hypothalamus, pituitary, and adrenal axis, or HPA axis. One of the main players in this axis is the hypothalamus, which produces corticotropin releasing hormone, or CRH, which then stimulates the pituitary gland to produce ACTH, or adrenocorticotropic hormone. And ACTH is the hormone that stimulates the adrenal gland to produce several different steroid hormones, as well as catecholamines, depending on which layer or zone of the adrenal gland that you're in. Some of the key players are going to be aldosterone, cortisol, which is one of the main stress hormones, and adrenal androgens, as well as catecholamines, which obviously have pretty significant physiologic impact in the autonomic nervous system. And then all of these hormones and catecholamines then provide a feedback mechanism back to the pituitary gland and hypothalamus to regulate the production of CRH and ACTH. And in normal healthy state, this is a very tightly controlled pathway and feedback loop that results in homeostasis. However, in critical illnesses, when somebody gets sick, several parts of this pathway gets disrupted. First of all, when the body recognizes the stress state, the autonomic nervous system can induce ACTH production independent of the hypothalamus and pituitary. And also the local inflammation in the inflamed tissues can also stimulate the production of CRH and ACTH from the hypothalamus and pituitary as well. And the inflamed tissues can also result in extra cortisol production by directly stimulating the adrenal gland independent of the ACTH. So as you can see, there's a lot of extra players that are now getting involved in this pathway, providing extra signals and dysregulated signaling mechanisms. So a lot of the normal physiology gets disrupted whenever there's stress in the body. And in addition to some of the effects from the local inflamed tissues, some of the systemic inflammation that occurs in critical illnesses can produce a lot of cytokines. And the cytokines themselves can also activate the HPA axis on its own and result in a lot of extra or dysregulations in stress hormone production. And that also results in dysregulation of the feedback loop that goes back to the hypothalamus and pituitary. So a lot of the signaling pathways start acting in an abnormal way. And outside of this HPA axis and the hormones that are involved, it's further downstream at the tissue or end organ level. There's also alterations in corticosteroid metabolism, as well as tissues that start to develop resistance to some of the corticosteroid hormones. So the tissues can also start responding to these stress stimuli in a very abnormal way. So the whole pathway just gets really disrupted and dysregulated. And this is sort of the general physiologic concept behind critical illness-related corticosteroid insufficiency, or CIRSE. It's a state of impairment of the HPA axis that occurs during critical illness, which results in inadequate cellular corticosteroid activity for the severity of critical illness. So the amount of corticosteroid activity may not be appropriate for the severity of critical illness to be able to mount the appropriate amount of inflammatory response. So either the body is not able to mount a sufficient inflammatory response, or in some cases, it can also go into like a hyperinflammatory state as well. So that the careful balance is lost very easily. And it can also be associated with insufficient intracellular anti-inflammatory properties that are mediated by the glucocorticoids, which then further exacerbate some of the pro-inflammatory processes and cause further organ damage and tissue damage. So CIRSE results from a state of systemic inflammation, which results in dysregulation of hypothalamus, pituitary, and adrenal axis. And that's associated with altered cortisol metabolism and tissue glucocorticoid resistance, leading to dysregulation of a lot of physiologic processes and tissue damage and organ damage in critical illnesses. And so that's the sort of the central concept behind behind a lot of the things that we're going to talk about. And the syndrome that's most closely related to CIRSE that I just mentioned is probably sepsis. Sepsis, by definition, it's a dysregulated host immune response to infection. So from a conceptual standpoint, it's very closely related to a lot of things that we just talked about. In terms of the rationale for using steroids or the physiologic rationale in sepsis, sepsis is associated with the production of a lot of pro-inflammatory cytokines in response to infection. And through a lot of the mechanisms that we just talked about, it can suppress cortisol response to ACTH and also start competing with some of the glucocorticoid function, leading to some of the inappropriate inflammatory responses at the cellular level. And that can lead to CIRSE in patients with sepsis, which can, like I just mentioned, it can precipitate organ failure. And in some cases, it can actually also impair the body's response to vasopressors, which is a critical problem in sepsis because we rely on vasopressors and catecholamines most often to reverse some of the physiologic consequences in sepsis. So in order to address all of that, the concept of using exogenous steroid medications to combat this mechanism is not necessarily a new thing. And there's been clinical trials as early as 1980s that looked at steroids to treat sepsis. However, back in the day, they actually used some of the initial or like early trials used doses of steroids that are much higher than what we're typically using nowadays. They sometimes used hydrocortisone 400 milligrams per day or equivalent, or sometimes even higher, generally for like a very short period of time. And some of the earlier trials actually showed increased mortality with the high-dose steroid regimen, even though there was a signal for benefit in terms of shock reversal if the steroids were given early. So that sort of led to subsequent clinical trials that used a slightly lower dose of hydrocortisone to hopefully avoid some of the complications and side effects from steroids. But unfortunately, these trials produced some conflicting results in terms of their clinical benefit with lower dose steroid regimens. To sort of reconcile some of the differences seen in earlier clinical trials, there was a Cochrane review that was performed in 2015 that included 27 trials of corticosteroids in sepsis. And this Cochrane review actually concluded that steroids reduced 28-day mortality for sepsis, but they recognized the limitation that there was a lot of heterogeneity in terms of the types and the dosing of steroids used, kind of going from like the higher dose to lower dose strategy and different durations of therapy. Some of the other findings that they noted was that, sort of consistent with what was seen with earlier trials, steroids resulted in higher rates of shock reversal, but it also had some negative consequences, such as higher rates of hyperglycemia and hypernatremia as well. Interestingly, there was some concerns about GI bleed and superinfection with steroids, but this particular Cochrane review did not identify any increased risk of GI bleed or superinfection. And one interesting finding from this Cochrane review was the fact that they performed some subgroup analyses based on whether the patient was requiring vasopressors or not. And they noticed that the benefit with steroids was actually more pronounced in patients with septic shock, whereas in patients who had sepsis but without shock didn't seem to have significant benefit from steroid therapy. And sort of supporting this notion, there was also a major clinical trial called the HYPERS trial from 2016 that specifically enrolled patients with sepsis but without shock and gave either hydrocortisone taper or placebo. And sort of confirming the findings from the Cochrane review, there was no difference in terms of people who went on to develop septic shock, and there was also no difference noted in terms of the mortality outcomes as well. So based on the available evidence up to that point, the 2017 guidelines from SCCM for sepsis, because there was less benefit seen in patients without shock, they suggested against using steroids in sepsis without shock, but they recommended giving steroids in patients with septic shock. But based on the clinical trial evidence, they defined the patients who might benefit from it the most as those who are not responsive to fluid boluses and moderate to high dose vasopressors. So the patients generally needed to be on a certain dose of vasopressors before they would be considered for steroid therapy. And based on the earlier clinical trials showing some harm with higher dose strategy, the 2017 guidelines recommended using low dose and long course of therapy, which meant IV hydrocortisone less than 400 milligrams per day for a duration of at least 3 days. But the timing was not so ideal with the publication of the 2017 guidelines, because within a couple years of the publication, 3 other major clinical trials got published examining the role of steroids in patients with septic shock. All 3 of these trials enrolled patients with septic shock plus or minus mechanical ventilation. And just to highlight some of the major findings, these trials also tested slightly different combinations of medications. The common denominator is the hydrocortisone, but one of the trials also looked at vasopressors in combination with that. And the Approaches trial looked at the hydrocortisone plus fludrocortisone combination in comparison with the placebo. The main conclusions were that hydrocortisone by itself didn't seem to result in a significant mortality difference, although in the adrenal trial, hydrocortisone was associated with faster resolution of shock, sort of consistent with the earlier studies. And interestingly, the hydrocortisone plus fludrocortisone combination seemed to demonstrate a slightly stronger signal for lower mortality with steroids in septic shock. So including some of the newer clinical trials and other evidence, when the committee met again to put together the 2024 updates for the SCCM guidelines, they examined a total of 46 randomized controlled trials. And from these trials, they concluded that steroids may reduce short-term and long-term mortality in sepsis and septic shock, and may reduce ICU and hospital length of stay. So they had some meaningful clinical benefit with steroids. Interestingly, including some of the newer trials, they did not observe any subgroup effects based on steroid type, dose, or duration, and no subgroup effects between sepsis versus septic shock. So the question of whether steroids might be beneficial in sepsis patients without shock became a little bit unclear with this iteration. And putting all of that together, they concluded that steroids probably have small to moderate desirable effects in terms of treating shock, treating sepsis, particularly in patients with septic shock. And even though the relative effect might not be super impressive, because sepsis and septic shock are one of the most common and prevalent conditions in the ICU, even a small relative effect might translate into a large absolute effect when it's applied across large numbers of people. So that was sort of the rationale for justifying the recommendation for steroids. And they also noted that steroids were beneficial in septic shock regardless of the vasopressor dose, which was a slight change from before. But they still noted more adverse effects with higher dose and shorter duration regimens of hydrocortisone greater than 400 milligrams per day for less than 3 days. So based on this, I want to highlight the major recommendations from the 2024 guidelines. For this update, they recommend or suggest giving steroids in patients with septic shock, but there's no longer a specific vasopressor dose or like a dose requirement for vasopressors before you can be eligible for or before steroids are recommended. And it's also worth noting that no specific type, dose, or duration of steroids are recommended specifically for treatment of sepsis. And that's because there's just too many variations across different clinical trials in terms of the regimens that they used. And they still recommend against using high dose and short course of steroids, like I just mentioned. And this is just a table sort of highlighting and comparing the recommendations from the 2017 and 2024 guidelines. For patients with sepsis without shock, if the patient is not requiring vasopressors, in 2017, they specifically suggested against using steroids, but in 2024, they make no specific recommendation. For patients with septic shock, the recommendations are sort of the same in the sense that they still suggest giving steroids, but like I mentioned, there's no specific vasopressor dose that's needed before somebody can be considered for corticosteroid therapy. In terms of the regimen, both of the guidelines basically say the same thing, just in opposite terminology. In 2017, they suggested giving low dose and long course. In 2024, they sort of just switched the words around, and they suggested against using high dose and short course. So those are sort of the major differences between 2017 and 2024 guidelines for steroids in sepsis. And with that, we'll switch gears a little bit and start talking about steroids and ARDS. So ARDS, just to remind everyone, is a syndrome of acute diffuse inflammatory lung injury that occurs within the first 7 days of a clinical insult or onset of respiratory failure. It's precipitated by a predisposing risk factor such as infection, pneumonia, or sepsis, sometimes trauma or blood transfusions, and a bunch of other risk factors can cause ARDS as well. And they all lead to sort of the common pathway of inflammatory lung injury that causes non-cardiogenic pulmonary edema associated with severe hypoxemia, bilateral opacities on chest imaging, and high mortality rates ranging up to 46% in severe cases. And using steroids to treat ARDS is also goes back a long way. Basically, ever since the first major definition of ARDS was published in 1994, there's been constant stream of clinical trials looking at steroids in ARDS. And I'm just highlighting just a few of the well-known or like the major ones here. But as you can see, there's also significant heterogeneity in terms of the clinical trial population, as well as the steroid regimen used. And because of that, even though some of the trials showed some reduction in mortality, it's sort of difficult to draw any like generalizable or definitive conclusions from these trials because of the variations between the studies, as well as some of the smaller sample sizes used in some of the clinical trials. However, I do think that some of the earlier trials sort of supported the notion that anti-inflammatory properties of steroids can be useful for sort of combating the inflammatory lung injury that occurs in ARDS. And in addition to that anti-inflammatory properties, I think when that translates into some of the other outcomes, corticosteroids can also reduce markers of systemic inflammation, reduce the duration of mechanical ventilation, and help people get better from their respiratory failure faster, and probably reduce mortality to a certain extent. One interesting caveat from the earlier evidence for steroids in ARDS is that at least based on the 2006 study called the Lazarus study, the timing of steroid treatment in ARDS also seemed to matter a lot. This clinical trial specifically enrolled patients who had ARDS for at least 7 days, so people who were a little bit further along in their ARDS course. And they were randomized to either methylpred, taper, or placebo. And the trial actually didn't note any mortality difference at 60 or 180 days, regardless of whether a patient received steroids or not. But another interesting finding was that when they looked at a subset of patients who were enrolled really late in the course of ARDS, at least 14 days after ARDS onset, in that population, the steroids actually seem to have higher mortality in that group. So the general belief based on this trial was that if you're going to use steroids for ARDS, it should be started early. And if you start it too late, then it might actually be harmful in ARDS. So based on this evidence, when they put together the 2017 guidelines, they suggested giving corticosteroids specifically in early and moderate to severe ARDS. So for that, your P to F ratio should be less than 200, and you need it to be within the first 14 days of ARDS onset, sort of based on the Lazarus study that I just highlighted. And the 2017 guidelines actually included a couple of dosing regimens that could be used for based on the timing of therapy, as shown in this table. So for early severe ARDS versus unresolving ARDS a little bit later in the course of disease, you had a couple different steroid regimens to choose from. And then, of course, after the guidelines were published, now we have more recent evidence. The first major trial that I want to highlight is the DEXA ARDS trial from 2020, where they randomized patients with moderate to severe ARDS with P to F ratio less than 200 to either a course of dexamethasone, 20 milligrams per day for 5 days, followed by 10 milligrams per day for 5 days, versus just being continued on routine standard care. And in this trial, patients who received steroids or dexamethasone had higher mean ventilator-free days and had reduced mortality. So this was one of the more recent major trials that showed mortality and clinical outcome benefit with steroids in ARDS. And of course, we also have to acknowledge the evidence that we accumulated from the pandemic as well. I just want to highlight the recovery trial, which was the major trial looking at dexamethasone in COVID-19 versus usual care. The regimen here was a little bit different. It was 6 milligrams a day for 10 days. And dexamethasone group had significantly lower mortality, specifically in sicker patients requiring invasive mechanical ventilation or oxygen support in the ICU. So that also supported the notion that people who have hyperinflammatory response to COVID infection are the ones who seem to benefit more from steroid treatment and from the anti-inflammatory properties. So with that, the guideline committee examined a total of 18 randomized controlled trials for updating the guidelines for 2024. And their conclusions based on their analysis was that steroids probably reduce 28-day mortality in ARDS and may reduce the duration of mechanical ventilation and hospital length of stay, although the certainty regarding some of the evidence and analyses was low. And interestingly, they didn't notice any subgroup effects based on steroid type, dose, and initiation time. So sort of contrary to the results from the Lazarus study, the initiation time of steroids didn't seem to matter when you incorporate the newer evidence. And there was also no subgroup effects based on COVID-19 status as well. And they believed that steroids may offer moderate desirable effects in terms of treating ARDS. And but they also recognize some important limitations as well. They acknowledge that there's lack of evidence or certainty regarding some of the adverse effects from steroids, as well as long-term outcome data, especially in like post-ICU survivor population, whether they might experience any long-term side effects that might not be readily apparent immediately in their acute illness phase. And even though steroids are generally cheap and certainly a lot cheaper than a lot of the other things that we typically do for ARDS patients, but the cost effectiveness of steroids and ARDS treatment has not been studied extensively. And then another interesting update was that when they performed some pooled analyses incorporating COVID-19 ARDS patients in their study, they noticed that there was no significant subgroup effects based on the severity of ARDS. And like I mentioned, the timing of initiation of steroid treatment didn't seem to matter as much, incorporating the new evidence. So that led to the removal of the P to F ratio and timing qualifiers from the recommendations. So with that, the 2024 guidelines for ARDS, they still suggest giving corticosteroids to critically ill patients with ARDS, but like I just mentioned, they decided to remove the P to F ratio and timing qualifiers. So now there is a little bit more flexibility in terms of treating patients with mild ARDS or patients who might be a little bit further along in the course of ARDS. And there's no specific steroid regimens that are recommended over another, but the DEXA ARDS regimen is now included as a common regimen that can be considered as an option. So again, just another table comparing the 2017 to 2024 guidelines. Both of the guidelines suggest giving steroids in ARDS, so there's no major changes there, but the main difference is that there's no longer a specific PF ratio or timing criteria for giving steroids in ARDS. And now there is the DEXA ARDS protocol that's included as a part of the option or the menu list for steroids in ARDS. And that's shown here at the top using the dexamethasone. So with that, finally, we'll talk about steroids and community-acquired pneumonia. The rationale is relatively straightforward, that pneumonia, just like any other infection and sepsis, leads to pulmonary or local and systemic inflammation, and corticosteroids have anti-inflammatory and immunomodulatory effects that may be beneficial for sort of preventing the inflammatory and steroid metabolism abnormalities from progressing. And there's also been plenty of clinical trials that looked at steroids in community-acquired pneumonia. But as you can see, there's a lot of heterogeneity in terms of patient population and how they like the inclusion criteria used and the steroid regimen that was used as well. So there's still a lot of heterogeneity. And they tried to sort of reconcile the differences between clinical trials in a meta-analysis in 2018, but they actually didn't notice any difference in mortality. But steroids did seem to show some secondary benefits, including shorter time to clinical stability and shorter hospital length of stay. So for this, for the 2017 guidelines, they also looked at a very similar set of data, and they noticed that some of the clinical trials showed some signal towards mortality reduction with steroids and CAP, and that seemed to be most pronounced in patients with severe CAP. And in addition to that, steroids seem to have some other benefit in terms of shortened hospital stay, reduced need for mechanical ventilation and prevention for ARDS. But also the steroids were associated with increased risk of hyperglycemia, so it was not without consequences. So based on that, the 2017 SCCM guidelines actually had like a relatively short section on community-acquired pneumonia. They suggested using steroids in hospitalized patients with CAP, and similar to sepsis, they recommended a dosing strategy that was on the lower dose of hydrocortisone, less than 400 milligrams per day, for a duration of 5 to 7 days. And then, of course, after the publication of the 2017 guidelines, we have some more recent evidence. One of the major clinical trial that I want to highlight is the Cape Cod trial, which you might be familiar with. This trial enrolled patients with severe CAP requiring ICU admission specifically, so very relevant for our population. And they were randomized to either receive hydrocortisone or placebo. I will point out that the dosing regimen and like the schedule that they used was a little bit interesting in that it was hydrocortisone 200 milligrams per day, but the duration could be varied depending on whether the patient was showing clinical improvement or not. So you could either give 4 days and taper quickly versus start with 7 days and then taper over a longer period of time, depending on the patient's clinical improvement. But in any case, the bottom line was that steroids reduced 28-day mortality in patients with CAP requiring ICU admission. And then the steroids, the hydrocortisone group also had reduced requirement for progressing to invasive mechanical ventilation or vasopressors. So it did show some meaningful improvements in clinical outcomes with hydrocortisone and CAP. So with the Cape Cod trial and some of the other trials, for the guidelines, they examined a total of 18 RCTs, including both severe CAP and less severe CAP. And they found that corticosteroids probably reduce hospital mortality in severe CAP specifically. And it also probably reduces the need for invasive mechanical ventilation and progression to respiratory failure in patients who start out with, even in patients who start out with less severe CAP. And it may also reduce the duration of ICU and hospital length of stay, although the certainty is low regarding that particular piece of information. So putting all of this together, they concluded that steroids offer large desirable treatment effects in severe CAP, but the benefit is less pronounced in less severe CAP. Some potential side effects to be mindful of include hyperglycemia and secondary infections. So those are sort of the major ones that they, or more significant ones that they identified. And another major limitation so far is that the definition for what counts as what is considered a severe CAP is really variable across studies. And I'll just highlight some of that here. Some of the studies use the ATS and IDSA criteria. Cape Cod's trial used a slightly different criteria. And then some of the other trials use different risk stratification scores to define the severity of pneumonia. So the study definitions are really variable, so it's a little bit unclear what might be the best way to define severe CAP. But for the purposes of the 2024 guidelines, they decided to go with hospitalized patients with severe bacterial cap as sort of the qualifier for receiving steroids. The guidelines recommend giving steroids to patients with patients who are hospitalized with severe bacterial cap, but like I mentioned, they acknowledge that the definition of severe sort of varies across different studies. And similar to sepsis and ARDS, there's no specific steroid regimen that's considered superior to another, so there's no specific recommendations for that. And the committee decided not to make a specific recommendation for steroids for people with less severe cap for this version. So again, comparing the changes from 2017 to 2024, the overall recommendation is very similar in that they suggest giving steroids for patients with cap. Before it used to be hospitalized patients with cap, but now they sort of specify or use a more specific terminology saying it should be given for severe bacterial cap in patients who are hospitalized. In terms of regimen, they no longer have a specific recommendation for this hydrocortisone regimen, so there's no specific regimen that's recommended, but these are some of the options that you can choose from, including the Cape Cod regimen, as well as some of the other methylpred-based steroid regimens. So those are sort of the major recommendations from the 2024 guidelines, and I'll just give a quick summary here. For sepsis, they suggest using steroids in patients with septic shock, regardless of the pressor dose, which is a slight change from prior. Excuse me. And they recommend against using high dose and short duration of steroids. And for ARDS, they suggest using steroids in critically ill patients with ARDS, but as I mentioned before, there's no longer a P to F or timing qualifier for ruling out steroids in certain cases. And for CAP, they recommend steroids in patients who are hospitalized with severe bacterial cap, but no specific recommendation for patients who are hospitalized with less severe cap. And with the recommendation, the guideline committee also recognized several ongoing limitations and areas of research, some of which I'll highlight here. First of all, vast majority of the clinical trials were done in adult population, so we really don't have great evidence for using steroids in critical illnesses in the pediatric population. So some more studies are needed in that specific population. And there are some special cases of patients who may have other critical illnesses on top of sepsis, such as critical surgeries or neurologic injury, who may have some other reasons to use or not to use steroids depending on their specific situation. For example, in surgical patients, steroids can impair wound healing and anastomosis, and in certain neurologic cases, some of the mineralocorticoid effects of steroids can hamper with the electrolyte balance or other issues in terms of like intracranial pressure monitoring and management and things like that. So there may be some very specific scenarios where steroids may or may not be so beneficial, even in the case of sepsis that would otherwise meet the criteria for giving steroids. So these are some populations that require special attention, and also the populations that need to be studied more in future clinical trials. And of course, we cannot completely rule out benefit of steroids in less severe CAP, so that's another population that needs to be studied more. And one of the major things that I want to highlight, and the area that I feel sort of passionate about, is the application of precision medicine approaches to giving steroids. Right now, we give steroids in a very non-specific way, basically just looking at whether somebody is on vasopressors or have ARDS or not, which in and of themselves can also be very heterogeneous and non-specific syndromes. So there's not a whole lot of like great or like very clear distinctions about like who should be receiving and who should not be receiving steroids. but it's very possible that certain phenotypes or subgroups of these patients may respond better to steroids, whereas some other phenotypes might not respond to steroids. And there's a lot of active research going on right now trying to figure out what are the phenotypes of sepsis, ARDS, and CAP that are most likely to benefit from steroids. I think I'm hoping that within the next several years, we'll have some better ideas and clarity about how to identify patients who are most likely to benefit from steroids in these critical illness syndromes, and learning more about patient-specific factors that may drive some of the treatment effect differences in specific subsets of populations. So I think I'm hoping that in the future we can be a little bit more intentional about how we give steroids in critical illnesses, but there's a lot of work that still needs to be done in this area. And as I mentioned several times throughout this talk, and also the guideline paper also mentions this a lot, because the clinical trials have used very different steroid regimens and dosing schedules, the optimal type and dose and duration of steroids is a little bit unclear. And to be completely honest, I'm a little less optimistic that there's not going to be any head-to-head clinical trials comparing different steroid regimens in sepsis, for example. But we'll see. Who knows? Maybe we'll get some updated recommendations in future guidelines about optimal steroid strategy in some of these syndromes. And like I mentioned, steroids overall are relatively cheap, but cost effectiveness of steroids needs to be studied, as well as patient and family viewpoints, just in terms of how they might view some of the potential complications or adverse effects from steroid treatments, and how that might factor in to the decision regarding giving steroids in critical illness. I think that needs to be studied more. And we are just starting to learn more and more about long-term and short-term consequences of steroid therapy that may not be readily apparent in clinical trials or when the patient is hospitalized. So I think that'll hopefully give us a better understanding of some of the unintended consequences of steroid therapy, again, so that we can be a little bit more intentional about who we give steroids to. And lastly, I think we also need to better understand the mechanisms of action and the pharmacology of steroids to be able to apply these medications more precisely in critical illnesses, and figure out who might benefit from these medications and what those medications might target in terms of reversing specific pathophysiologic mechanisms. So with that, I'll conclude my talk. Thank you for your attention, and thank you for the invitation to give this talk as well. And I'll be happy to take any questions at this point.
Great. Thank you so much, Dr. Yang, for the great summary and a very in-depth analysis of what the guidelines suggested. And just as a reminder, if you have a question for Dr. Yang based on what he presented or in his areas of research, feel free to put that in our chat box and we can read it and let him answer his question, the question for you. But in the meantime, I wanted to start you off on the Q&A session while people are putting their questions in. It seems like the 2024 guidelines gives more discretion to the treatment team as far as when to start, and the choice of steroids, and also kind of removing some of the restrictions as far as timing and things like that. So I was wondering if you could discuss, in your experience, what are some of the choices of steroids? Is it still go to the hydrocortisone, or do you feel like it's one of like the fifth antibiotic where it's like, oh, we'll start it, if it doesn't work, we'll stop it in a couple of days type thing, and if incidence is going up? I was just wondering if you could speak a little bit more about your experience.
Yeah, so kind of going outside of like the proven evidence and kind of venturing into like my personal style. With regard to sepsis, I generally think about starting steroids when the patient does not have a quickly resolving septic shock. So I know the guidelines recommend that there's no specific like vasopressor dosing that will qualify somebody for steroids, but sometimes we get these patients who sort of present really sick, but then they turn around pretty quickly with timely antibiotics and things like that. And they're able to come off of pressors within like the first 24 hours. So I think in those scenarios, I think if we believe that the early antibiotics and some of the other resuscitation measures have adequately treated the underlying sepsis, then I don't necessarily see a reason to start steroids in that scenario. But it's really when somebody doesn't have has like a lingering shock or persistent pressor requirement, that's when I would start considering steroids in septic shock. And I'm trying to push myself a little bit more towards using steroids regardless of the vasopressor dose, especially if they have persistent shock. For ARDS and CAP, I generally use the DEXA ARDS protocol because that's what I have the most experience and familiarity with. And for CAP, I started using the Cape Cod regimen a little bit more often, although depending on the specific patient that you might be dealing with, sometimes there might be additional considerations, especially for potential side effects and things like that, like hyperglycemia and secondary infections and whatnot.
Great, excellent. Thank you so much. Okay, we had received a question from the group and the audience, and I think you may have touched on this, but if you could also, again, going back to your clinical experience, how do you consider ordering steroids for patients who have CAP, sepsis, and pneumonia with concomitant COPD exacerbations? Are there biomarkers for inflammatory diseases that would benefit, or certain things like that?
Yeah, so I think those are probably two separate questions. So regarding the COPD exacerbation, I try to tease out, it's not always possible, but I try my best to sort of tease out or at least decide which disease process or like syndrome is sort of the primary driving factor for the patient's acute illness. For example, like somebody has like a consolidation, pneumonia, and like mild sepsis, but their primary presenting complaint was like wheezing and shortness of breath and more COPD exacerbation type of picture, then I would sort of treat it more like COPD exacerbation with the typical dosing for COPD exacerbation. But if somebody's ending up in the ICU with respiratory failure requiring BiPAP or septic shock, then whatever I think is like the most pressing component of their illness, that's what I sort of focus on to make my decision about the steroid regimen. But there's probably not like a proven like one right answer. You could reasonably treat for any one or all of those processes. And another common strategy that I sometimes think about is whatever will give the patient like the highest dose of steroids while trying to avoid some of the potential complications. I think that's another balance that I often think about as well. And in terms of the biomarkers for hyperinflammatory diseases, so I don't think there's great evidence about like any specific biomarkers outside of like research settings that are still ongoing right now. So I think for right now, we're still stuck with very non-specific inflammatory markers like CRP and ESR. Sometimes we can also use like procalcitonin if it's available at the institution to kind of help you distinguish some of the bacterial infection and inflammatory processes that might occur as a part of sepsis and critical illness. I'm hoping that in the future we'll have more biomarkers available at our disposal in like routine clinical laboratories to be able to distinguish these phenotypes and kind of identify the patients who might benefit more from steroids. But I think right now, as a lot of clinical like these tests are not necessarily available in clinical laboratories for the clinicians to be able to make decisions in real time, unfortunately.
Excellent. And one last question as far as your own research in this. Are you working on any projects right now that you're particularly excited about as related to this, or maybe separately, just from your own professional interest?
Yeah, it's not like specifically related to steroids per se, but my interest is in identifying the phenotypes of sepsis and respiratory failure. So I have some preliminary data that looked at different phenotypes, and there's some evidence based on retrospective analysis that some of the phenotypes might respond differently to things like fluids and steroids and things like that. So we're I'm trying to like implement the phenotypes into real-time ICU, like in the EMR, to hopefully validate it in a prospective manner and hopefully translate that into potentially like clinical trials or other clinical studies in the future.
Excellent. Thank you so much.
And one of the things that we might look at is do the phenotypes respond differently to steroid medications as well?
Absolutely, yes. I think that speaks to your bullet point about the precision medicine and kind of how do you differentiate the response, and does that determine who receives it up front?
Right. Yeah.
Great. Thank you. Well, thank you so much, Dr. Yang, for providing a detailed and very useful summary of the guidelines. Just as a reminder for our audience, if you want to claim CE, remember that the deadline is 2 weeks from today, which is July 8th. And if you need the information to the evaluation form, please email communications@sccmse.org. And this will conclude our quarterly meeting for June 2025. Thank you so much, Dr. Yang, for providing this wonderful presentation. And have a good evening, everyone.
Great. Thanks for having me.